I'll be speaking next about a topic that's hopefully relevant to your practices. We're all prescribing direct anticoagulants, and the question that is asked is, when is a half dose appropriate? I have no disclosures. So when we talk about reducing the dose of a direct anticoagulant, there are two clinical scenarios in which this typically takes place. The first is when you're doing an actual dose adjustment with a goal of maintaining full intensity therapy, full anticoagulation, but you have some concern regarding increased bleeding risk due to advanced age, decreased weight, or concomitant liver or kidney disease. The second scenario is actually with an intent to decrease the actual intensity of anticoagulation, and that usually falls under the circumstance of prophylaxis long-term against venous thromboembolism. The next few slides are going to be discussions of essentially the FDA drug inserts for apixaban, rivaroxaban, and dabigatran. And we're going to go through all the various FDA-approved indications, including non-valvular AFib, treatment of DVT-PE, extended treatment for DVT-PE after the initial treatment period, and VTE prophylaxis for total hip, total knee, and inpatient medical patients. We're all familiar with the dosing of 5 milligrams BID, prescribe it every week, I'm sure, as you do. But in the AFib population, there is a role for decreasing the dose to half, 2.5 milligrams BID, if two of the three criteria are met, which include age greater than 80, body weight less than 60 kilograms, or serum creatinine greater than 1.5. What we find in the real world is that there is an off-label tendency for clinicians to extrapolate from the AFib data and use that in the VTE data. And so you take a patient who may be a little frail, a little older, and then you say, oh, well, if it's in the AFib population to decrease the dose, we should probably decrease the dose in the VTE patient as well. But there is actually no data to justify this pattern of practice. And how about the patients with renal disease? We tend to be a little bit concerned about decreasing the dose of apixaban in patients with CKD, but actually there is no required dose adjustment in CKD, even in patients who need dialysis. Lastly, for apixaban, there is a half dose for extended treatment. So if you are done with the first 3 to 6 months of anticoagulation, then there is a FDA-approved and validated clinical trials that say that 2.5 milligram half dose is good for patients who are going to be continuing lifelong anticoagulation. Now into rivaroxaban. There are also FDA-approved indications shown here. With rivaroxaban, 20 milligrams daily. You decrease it because it has some renal clearance. You do decrease the dose to some degree from 20 down to 15 milligrams daily if the creatinine clearance is 30 to 50, and should be avoided if the creatinine clearance is less than 30. For extended treatment, half dose is also appropriate, 10 milligrams daily. It is also indicated for hip, knee, and inpatient medical patients. There are other indications for rivaroxaban, including prophylaxis against coronary disease events, PAD events, treatment of pediatric patients with VTE from birth to 18 years of age, and patients with congenital heart disease. In those particular situations, the dose is even decreased down to about a quarter of it, 2.5 milligrams BID, usually in combination with a baby aspirin. Obviously, for the VTE patients, the dosing is going to be based on weight, and those are a little bit too complicated to discuss here in this short talk. The last DOAC we're going to discuss today, which is dabigatran. We used to use it more heavily, but don't use it as much since the other agents are more available. This is still utilized in our VA population and is utilized by the Kaiser Health System to some degree. For its various indications, dabigatran for atrial fibrillation half dose is appropriate for lower creatinine clearance. If the patient does take a PGP inhibitor, which are antifungal and some anti-HIV medications, there is a requirement for a dose adjustment so to avoid buildup there. In contrast to rivaroxaban and apixaban, for extended therapy beyond the first 3 to 6 months, dabigatran actually you stay at the same dose of 150 milligrams BID. There is an indication for treatment of pediatric patients from 8 to 18 years of age, also weight-based dosing. And it is interesting that the weight-based dosing actually reaches the adult dosing of 150 milligrams BID when the kid is only 26 kilograms. So it achieves the adult dosing at a fairly low body weight. So those are the FDA-approved indications for half dosing in particular situations for lifelong anticoagulation, but there are still so many questions that remain to be answered in special populations. And in particular for vein patients, rivaroxaban, can it be used in patients with renal failure? What is the duration of anticoagulation in provoked VTE? We talk about unprovoked DVTs requiring longer-term anticoagulation, potentially lifelong, but there is still a low but real risk of recurrent DVT-PE in provoked patients as well. How do you treat isolated calf DVT? How do you prevent venous thromboembolism in cancer patients? What is the optimal therapy in patients who have heparin-induced thrombocytopenia, et cetera? So this is a patient you probably will have in your clinic, not necessarily her, but someone just like her. Let's call her Millie. She is, 82 years old. She had a calf DVT. You put her on apixaban anticoagulation, and she comes back to clinic for follow-up, and she just says that, oh boy, I've got some easy bruising. I'm bruising all over the place, and I don't know, I just really want to stop this anticoagulation. So the question arises is, does this nuisance bleeding, is it a harbinger of a worse clinical outcome of major bleeding? This actually was looked at in the Orbit AFib registry of over 6,700 patients, where they looked at patients who had nuisance bleeding, such as easy bruising, hemorrhoid bleeding, et cetera, but did not require medical attention. And they identified that it was not associated with an increased risk of major bleeding or an increased risk of stroke or systemic embolism. So where do we stand now? We get guidance from the hematologists, and this is a group from McMaster University, a very preeminent hematology group, and they give some guidelines with regard to direct anticoagulants and reducing the dosing. So what they conclude is that off-label dose reductions should be avoided in patients with isolated advanced age, patients who say they have frequent falls, patients with minor bleeding, partly because of that Orbit AF registry which I just showed you. But off-label dose reductions might be considered for patients who have recurrent major bleeding, particularly in the GI or GU tract, patients at high risk of life-threatening bleeding, such as esophageal varices, patients with a prior history of intracranial hemorrhage, or those with severe thrombocytopenia. So in summary, this is a short presentation, but in summary, when there is a long-term anticoagulation which is needed, half-dose apixaban is appropriate for patients with AFib if a few criteria are met, such as advanced age, decreased body weight, or some evidence of CKD. Extended prevention against recurrent VTE after the first 3 to 6 months of therapy. It's also appropriate to give half dose. For rivaroxaban, extended therapy, again, half dose after the first 3 to 6 months. Reducing the dose for AFib and patients with CKD, that has been possibly appropriate. And dabigatran is appropriate to reduce the dose in patients with AFib stroke prophylaxis, with CKD, and those concomitant antifungal and anti-HIV medications.